So, hello guys, with you, Dr. Hamid, an ECPMG certified physician. We are going to talk about the different kind of arrhythmias for the USMLE Step 1 exam. So, you know that arrhythmias are classified into narrow-complex tachycardias, and wide-complex tachycardias. So, the main differentiating factor between them is the QRS complex. So, you have here the QRS complex here, these 1, 2, 3, 4, 5 QRS complex, they are all narrow complex. So what we mean by narrow complex, it means essentially it is less than 120 milliseconds. This also means that it is equal to 3 small squares. So every small square is like 40 milliseconds. So 40 times 3 is 120. So this narrow QRS complex is less than 3 small squares. So this is the first condition. And the second is understanding about the physiology. So the ventricular activation is normal here, and the ventricular conduction is also normal, but there is some kind of foci or different kind of arrhythmia or tachycardia originating within or above the AV node. So from the AV node downward, there is nothing abnormal. So this is characteristic for the neurocomplex tachycardia. So the first arrhythmia is atrial fibrillation. So for the atrial fibrillation, the rate is irregular in terms of rate and in terms of rhythm. There is no discrete B wave. So first you have to look at the ECG and you find neurocomplex. Then you look for the B wave. You will find no B wave here. There is no B wave. So the arrhythmogenic activity usually originating from an automatic foci. The place for the automatic foci is very important. It is near the pulmonary vein ostia in the left atrium. You have to memorize that very well. For the atrial fibrillation, the origin of it is the left atrium, specifically near the pulmonary vein ostia. So in order to get an atrial fibrillation, you don't have to be diseased. So you may have some young female or male, they may have paroxysmal atrial fibrillation due to stress or caffeine or nothing at all. So and you may get atrial fibrillation for when you have some risk factors such as hypertension or coronary artery disease. You don't have to very big MI or scarring to get atrial fibrillation. You may have hypertension, coronary artery disease. So these kind of things may predispose you to atrial fibrillation, and the atrial fibrillation of itself may predispose you into some thromboembolic events. So there is a stasis of blood in the left atrium, and the embolus may form in the left atrium and go and cause a stroke or cause mesenteric vascular occlusion or AKI. So this kind of different kind of complication for the atrial fibrillation. So for the management, first you have to ask yourself a question: is the patient hemodynamically stable or not hemodynamically stable? For the acute management, if the patient is hemodynamically stable, you have to give him rate and rhythm control with drug. But if he is hemodynamically unstable, you have to cardiovert your patient. Cardioversion is treatment for hemodynamically unstable patient. And after the acute condition is stabilized, you will give the definitive treatment. So remember that the origin for the atrial fibrillation was the pulmonary vein ostia in the left atrium. So you have to ablate the pulmonary vein ostia area, and you may consider anticoagulation based on the stroke risk. So this something called CHA2 DS VASC. So this abbreviation for congestive heart failure and the age of more than 75 and stroke and the possibility of hypertension or stroke for a female. So if you have more than 2 points for this for the female or more than 3 points of this for the male, you have to give anticoagulation, as the patient may be a stroke risk. You don't have to memorize that, but I gave you a hint about this stroke risk parameter. And second thing is multifocal atrial tachycardia. This also irregular. So as the AF, you ask the same question, it is a narrow complex. Yes, it is narrow complex. So this is like AF, but you ask yourself the second question, do you see B waves? So here you see B waves. This is a B wave, and this is a B wave, and this is a B wave. So essentially you find three different patterns or more for the B wave. This is a B wave, big B wave, and inverted B wave. So irregular plus three distinct P wave morphologies. So this indicates different morphologies, indicates they originate from different multiple ectopic foci in the atria, and kind of associated with different kind of not only cardiac but also respiratory, such as COPD and pneumonia or heart failure. So you have respiratory and heart conditions will predispose you to multifocal atrial tachycardia, not famous arrhythmia as atrial fibrillation. And the third one is atrial flutter. So very characteristic picture is a consecutive atrial depolarization. They are like each other's, so they are very consecutive, and they look like sawtooth appearance. So you gives you the waves causing some peculiar tooth appearance. So the arrhythmogenic activity origin is different. Remember that for the atrial fibrillation, we talked about the pulmonary ostia in the left atrium. So this is the re-entry circuit around the tricuspid annulus in the right atrium. Different kind of origin. So treatment is essentially like atrial fibrillation, and after the acute episode is gone, you have to ablate the origin, which is the region between the tricuspid annulus and the inferior vena cava. This is in the right atrium, unlike the AFA, which is in the left atrium. For the last narrow complex tachycardia, here is the paroxysmal supraventricular tachycardia, which is BV, paroxysmal supraventricular tachycardia. So the patient may complain of palpitation or lightheadedness and diaphoresis. So this is a common complication. So the patient may complain of attacks that come and go. Not necessarily the patient will go in the attack and not resolve. So this is due to a reentrant tract between the atria and the ventricle. You know that between the atria and the ventricle is the AV node. Within the AV node is the problem here. So the problem here in the paroxysmal supraventricular tachycardia lies within the AV node itself. So a re-entry circuit within the AV node, you don't have to know the details for step one. So the treatment, you terminate re-entry rhythms by slowing the AV nodal conduction. The defect is in the AV node, so you slow the AV node by doing some vagal maneuvers or IV adenosine. So for the specific details, it is not very high yield. Don't bother yourself with specific details. Step one now is pass and failed, so you have to know the main things. So the vagal maneuvers is IV adenosine essentially. So for the vagal maneuvers is very effective in supraventricular tachycardia, but not so effective in F. So this is due to the different kind of morphologies, etiologies. Etiology here lies within the AV node, and if we do a vagal maneuver by manipulating the carotid artery, we will increase the vagal discharge and slow the AV node, so we will terminate the paroxysmal supraventricular tachycardia. Very effective vagal maneuver, very effective in this condition, and you may give IV adenosine also. And if the patient is hemodynamically unstable, as always, you give electrical cardioversion. And also after the acute attack is gone, you will ablate the foci, so the catheter ablation of the re-entry tract at the AV node. For the Wolff-Parkinson White syndrome, WBW syndrome, other name for it, WBW syndrome. So you will find the characteristic delta wave. So what is the delta wave? It's a pre-excitation wave. It's normally the QRS starts here at this line, but it starts earlier and give you the delta wave. And this leads to a shortened BR interval. The B start from the B to the starting of the R. So this is the normal BR interval. It is shortened here at Wolff-Parkinson-White. So the first thing is the delta wave. The second thing is the shortened BR interval. So this is the most common type of pre-excitation, ventricular pre-excitation syndrome. So the pathophysiology for this is the abnormal fast accessory pathway from the atria to the ventricle through something called the bundle of Kent. So for the supraventricular tachycardia, the problem lies within the AV node, so there is re-entry circuit within the AV node. But here it's unlike this. There is another fast accessory pathway coming from the side of the heart. It is called the bundle of Kent, along with the normal accessory normal pathway from the AV node. So you have two parallel pathways. The pathway from a bundle of Kent, fast accessory pathway called the bundle of Kent, and the bypassing the slow AV node. The AV node have a slow rate. It's slow with the discharge coming from the atria for the ventricles. This is its role. So there, when you have another fast accessory pathway, there is a very dangerous problem. So the ventricle partially depolarizes earlier. So this gives you the characteristic delta waves, the earlier depolarization wave. And the QRS will be widening due to the delta wave. The effect of delta wave leads to widening of the QRS complex, and the BR is shortened. Three effects: delta wave, pre-excitation wave, widening of the QRS, and the shortening of the BR interval. So this for the ECG in the Wolff-Parkinson-White syndrome. So the treatment, you give something called the procainamide and ibutylide. So the procainamide is a class 1A antiarrhythmic, and the ibutylide is a class 3 antiarrhythmic drugs. So we will go through them, but for now, know that the procainamide class 1A antiarrhythmic and ibutylide class 3. You have to know this as a base for you as you go on through the different kind of antiarrhythmic drugs. We will go through them at the end of this chapter. And very important notice here is to avoid AV nodal blocking drug. So the problem, you remember, is accessory fast pathway that is much faster than the AV node blocking the conduction between the atria and the ventricle. So if you made a mistake and give some AV nodal blocking agent, you will exacerbate the problem. You will remember that the AV node is slow already. When you go give a drug such as adenosine, calcium channel blocker, beta blocker, all the things that block the AV node, you will exacerbate the problem and kill the patient. So when you see this kind of pattern on the ECG, delta wave, shortened BR interval, widening the QRS, you know this is Wolff-Parkinson-White syndrome. It's contraindicated to give adenosine, calcium channel blocker, or beta blocker. Instead, if the patient have tachycardia from this or arrhythmia from this, you give him procainamide, class 1A antiarrhythmic, and ibutylide, class 3 antiarrhythmic drug. For the wide complex tachycardia, this is a different kind of story. Remember, in the narrow complex, it was less than 120, so here it is more than 120. You see how wide this complex, more than 3 small squares, and the defect here is below the AV node. So the slow ventricular activation outside the normal activation conduction system, and the tachycardia originates below the AV node. So the ventricular tachycardia, very famous arrhythmia. And the rhythm here is regular. You know this QRS and the QRS between them is equal. So this is a regular rhythm, and the rate is essentially more than 100, and most commonly occurs due to structural heart disease. You remember in EF, we said that the EF may come in a healthy individual or may have only hypertension or coronary artery disease, mild coronary artery disease. But here, to get ventricular tachycardia, very dangerous arrhythmia, you have to have a structural heart disease such as cardiomyopathy or scarring after a big MI. So when you have that, you may develop a ventricular tachycardia. If you get ventricular tachycardia subsequently, you are a high risk of sudden cardiac death. Unlike AF, you may get AF and it's all good, and even a lot of patients may live with chronic AF. So unlike ventricular tachycardia, you have to stabilize that. You won't see the patient in the street walking with ventricular tachycardia but you may find so many people living with AF. So this common condition here is the torsative one. So the torsative one, the figure is not very obvious. So it is a polymorphic ventricular tachycardia. So it's also a ventricular tachycardia, but polymorphic, has a sinusoidal pattern. It is widening and then narrowing, widening and narrowing, giving you sinusoidal waveform. And if you left it, you may progress into ventricular fibrillation, the most lethal arrhythmia, ventricular fibrillation. So what causes torsative wa long QT interval? What causes long QT interval out of drugs? You may remember this by a patient who coming in the ICU. You give this patient antibiotics such as macrolides and fluoroquinolones, and then give the patient antifungals such as fluconazole. A random patient going to the ICU, you give him antibiotic macrolides. This is an example to help you remember the causes of torsative ones, or causes of long QT intervals that leads to torsative one. So antibiotics, macrolide and the fluoroquinolones, antifungal fluconazole. The patient may want to vomit, and you give him ondansetron or Dancet antiemetic, very common in the ICU. The patient may go into ICU psychosis, or after or before may have the depression. So you may give him antipsychotic, haloperidol, and antidepressant, tricyclic antidepressant, very common for the patients. We covered most of the drug, and of course nalorphine or the opioids, methadone, very common drug to use. And this leaves you the antiarrhythmic drugs. You remember the antiarrhythmic drugs we used for Wolff-Parkinson-White syndrome, brokinamide class 1A and butylite class C. These drugs treat Wolff-Parkinson-White syndrome, but on the other hand, they may cause torsative ones. So this antiarrhythmic 1A and 1C, and arsenic and diuretics. So diuretics, in kind of diuretics, leads to electrolyte disturbance. So electrolyte disturbance itself is a cause for torsative by decreased potassium, magnesium, and calcium. So diuretics and the electrolyte disturbance that it causes leads to torsative ones. So the last lethal rhythm is ventricular fibrillation. So unlike any other rhythm, very lethal, and most of the patient dies, and the treatment is fatal without immediate CPR and defibrillation. And even if you do that, most common outcome is death. So for this, you will see no identified rhythm, disorganized rhythm, no identifiable waves. This is a ventricular fibrillation. So the next topic, much lower yield, is the hereditary channelopathy. From its name, it is hereditary, and the defect in the channels. So the defect in the ions, it's an inherited mutation and abnormal action potential. So the ventricular arrhythmias risk is increased, and the sudden cardiac death or skid. So we have two examples, of Brugada syndrome and the congenital long QT syndrome. For the Brugada syndrome, the inheritance is autosomal dominant, and the defect lies in the sodium channels. You know that you have to know that the defect is in the sodium channels. You don't have to know so much further details. It is autosomal dominant, and the defect at the level of the sodium channels. So for the ECG pattern of Brugada, pseudo right bundle branch block and ST segment elevation in the V1 and the V2. So you know, right bundle branch block means the QRS widening, and RSR, you have R is going up, S is going down, and RSR is like a rabbit ears. It occurs in V1 and V2. Plus widening of the QRS is a characteristic for right bundle branch block. So you see pseudo right bundle branch block plus ST segment elevation in the V1 or V2. You don't have to know these details, but if you we covered that. This is with the history of someone in the family or so. It is actually a autosomal dominant condition. This is Brugada syndrome. For the congenital long QT syndrome, it has the two subcategories: Roman-Ward syndrome and Gervil and Lang-Nielsen syndrome. I'm not sure about the pronunciation, but for the Roman-Ward syndrome, you know that the patient in the ward is stable, so he does a clue to remember that he doesn't. You don't have deafness. Both in the both conditions, you have QT prolongation. So the defect here on the potassium channels You know that the potassium channels is responsible for the repolarization, and the repolarization in the ECG is represented by the QT interval. So the defect here in the QT, and subsequently it is in the potassium channels. It is very logical. So the two categories: Roman-Ward syndrome, no deafness, and the Jervell and the Lange-Nielsen syndrome, sensorineural deafness. And you remember that the grave diseases or the bad diseases are autosomal recessive, and the good diseases are autosomal dominant. So Roman-Ward syndrome, autosomal dominant, no deafness, while Jervell and the Lange-Nielsen syndrome, autosomal recessive and sensorineural deafness. The sick sinus syndrome, from its name, sick sinus syndrome, it is the sinus syndrome or the SA nodes, which is responsible for the P wave, become sick. So it may lead to bradycardia or sinus bosses if it just occurs like this for 1 or 2 seconds. If it occurs for more than 2 seconds, it becomes a sinus arrest. So you may have sinus bosses as here. Sinus bosses, the B wave stops here, and subsequently the QRS here have no preceding B wave. This is a sinus boss for 1 to 2 seconds. Goes further and it becomes more maybe sinus arrest and bradycardia, of course. And there are some kind of beats, junction escape beats that have no preceding P wave. This for the arrhythmia, and for the abnormalities in the conduction system, you have three: the first degree heart block, the second degree heart block, and the third degree or complete heart block. For the first degree heart block, the BR interval, BR1 or BR interval is essentially the same. BR interval here equals here, but the problem, it is prolonged in all of the leads, all of the QRS and the B waves. So the BR interval is prolonged in all over the ECG. What we mean by prolonged means more than 200 milliseconds. So you remember each small squares is 40, so 200 milliseconds is more than 5 small squares. If it is more than 5 small squares and it is consistent throughout the ECG, so this is a first degree heart block. And the treatment, none. It is a benign condition, asymptomatic condition. You don't have to worry about that. Second degree heart block is further subdivided into Mobitz type 1 or Winkbach or Mobitz type 2. So for the Mobitz type 1, there is progressive lensing. You remember the first degree, the BR interval was the same throughout the ECG, but here the BR interval 1 keeps progressing and increasing in size till we reach a dropped wave. The B wave here not followed by subsequent, the B wave here not followed by subsequent QRS complex. So the BR interval keeps increasing here till the B wave not preceded by QRS. So this Mobitz type 1 Winkbach, a progressive lensing of the BR interval until a beat is dropped, B wave not followed by a QRS complex. And so regularly irregular. So irregular, what this means that it increases 1 2 3 and then we drop the beat, and this keeps going on. So it has a pattern. So this means this is the meaning of regularly irregular. Treatment also non-asymptomatic. This is Mobitz type. You have to remember the Mobitz type 1 is the good, the benign, no treatment. But Mobitz type 2, and there are dropped beats not preceded by changes in the BR intervals. The BR interval is the same like first degree heart block, but suddenly a B wave not followed by a QRS complex. This is Mobitz type 2, and it is an indication that this patient may progress into a third degree heart block, and you may consider the pacemaker. Not 100%, but usually you may give a pacemaker. For the third degree heart block, the treatment is always pacemaker. So the second degree heart block, Mobitz type 2, maybe or usually you a pacemaker, but the third heart block, the third degree heart block, you always treat with a pacemaker. Here the B waves and the QRS each have its own, or each dances on its own rhythm. So this is a B wave. It is the space between them is fixed, and it is as a space here. This is the next B wave, this is the next B wave, this is the next B wave, which came along with the QRS. So they came with each other. The B wave, this is a T wave, so the B wave and the B wave. So it is have a normal rhythm, but for the atria, and this is a QRS, have also normal rhythm. So the QRS to the QRS, from the QRS to the other QRS, having a normal rhythm. So the ventricles have a rhythm on its own, and the atria have its own rhythm on its own, and they are dissociated. Nothing has to do with the other. So the atria and the ventricle beat independently of each other. But if you notice, the atria rate here is more than the ventricular rate. This is a very normal. The cause of this may be Lyme disease. We will go through this in the infectious disease chapter. For the bundle branch broke, we will go through this. This means interruption of the conduction of a normal left or right bundle branch. The defect in the bundle branch itself. The affected ventricle depolarizes via slower myocyte to myocyte conduction. So if you eliminated the right or left bundle branch, the cardiac muscle has to depolarize through the myocyte to myocyte conduction from the unaffected ventricle. The depolarization comes from the unaffected ventricle, as the bundle branch that is perfusing or supplying this ventricle is diseased. So the commonly it occurs due to cardiomyopathy or infiltrative disease, all of that. So lastly, the premature beats. So you have premature atrial contraction or premature ventricular contraction. So for the premature atrial contraction, you may find this in some people who take caffeine. This is a premature atrial contraction. This is an extra beat coming from an ectopic foci of the atria. You have B wave here, so it comes from the atria. But it came earlier means that it's ectopic, means that it's premature. So for all of this from the meaning, premature came prematurely, premature atrial contraction, extra beat that came prematurely from an ectopic foci instead of the SA node. Not from the SA node as this B wave from the SA node due to increased adrenergic drive from caffeine, for example. It's benign, but not completely benign, may increase the risk for AF or flutter. The complex is narrow complex with preceding P wave, but it came from the atria, this P wave, but not from the SA node, from other foci, from an ectopic focus. For the mature ventricular contraction, is ectopic beats arising from the ventricles instead of the SA node. So it came from the ventricle instead of the FA node. No B waves because it came from the ventricle. This is the BVC or premature ventricular contraction. Is known for BVCs. The effect of that. It came early, so when it came early, this allows for shorter diastolic filling time, and subsequently decreases stroke volume compared to normal beat. And the prognosis is dependent on the underlying heart disease, what causes a BVC. If it is minor, then it is non-significant. If the disease itself is major, so you are in danger here. So you will have a white QRS complex, no preceding B wave on ECG. The source of the problem is the extra beat arising from the ventricle. Has nothing to do with the SA node. And thank you. This completes our session today for the different kind of arrhythmias for the USMLE Step 1 exam.